Hi, everybody, and welcome. My name is Neil Seidman, and I'm the co-chair of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. And welcome to our webinar. The topic is, for my anxiety or depression, should I use medication or therapy? And we're privileged to have two presenters, Dr. Andrew Rosen and Dr. David Gross. So before we start, I'd like to just say a little about ADAA, the Anxiety and Depression Association of America. ADAA is the leading nonprofit organization in the field of anxiety and depression. Our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, practice, and research. We work to end stigma and to get the word out that all of these conditions are real, serious, and treatable. I want to invite you to visit the ADAA website. It's really a wonderful resource. It's adaa.org. And one of the things you'll find there is a really wonderful list of treatment providers. And in addition, we have a peer-to-peer, free peer-to-peer online support group that you can also find on the website. And finally, you can support ADAA by making a charitable donation on the website. So let's get started. I'm really happy to introduce our presenters. Dr. Andrew Rosen is the founder and director of the Center for the Treatment of Anxiety and Mood Disorders, which is located in Delray Beach, Florida. He started the center in 1984 in order to focus more attention on the problem of anxiety disorders. Dr. Rosen has written numerous articles and books and has appeared as a professional authority on many television and radio shows. Dr. David Gross, MD, is a Distinguished Life Fellow of the American Psychiatric Association. He is a board-certified psychiatrist with almost 40 years of clinical practice experience. He's also past president of the Florida Psychiatric Society. Dr. Gross takes a holistic approach. He combines traditional psychiatric treatment with alternative medicine, including acupuncture. Dr. Gross is in private practice in Delray Beach, Florida, and he's the medical director of the Center for Treatment of Anxiety and Mood Disorders in Delray Beach, Florida. So let me turn the presentation over now to Dr. Rosen and Dr. Gross.
It's our pleasure to be here. This is Dr. David Gross.
And this is Dr. Andrew Rosen.
And we're very excited to be able to discuss with you today a very critical topic for ongoing evaluation and treatment of mood and anxiety disorders. Specifically, for my anxiety or depression, should I use medication or should I use therapy? A question I'm sure many of us have raised questions over the years about. The essential approach both of us have taken to the evaluation and care of individuals who come to us for help is what's best described as a biopsychosocial model. It sounds much more complicated than it really is. It refers to the whole person, which can be divided into a biological sphere, which is how our body and brain works, the psychological sphere, which has to do with how we think and cope and deal with the world, and the social sphere, which has to do with what the world around us is like and how it impacts upon both our biological processes as well as our life experience psychologically. What we realized many, many years ago working together, and we've been working together since 1992, is that the best approach really is to be integrated, to combine the work of our different disciplines with the sole goal of helping an individual improve, which requires ongoing communication, which is often easier said than done.
Yes, and as a psychologist, over the years, it was rather typical for a patient to come in, whether they were experiencing anxiety or mood disorders, and to ask the question, well, is this chemical or is it psychological? And it goes back to that whole nature-nurture issue, which nobody's really ever been able to help educate the public that it's not one or the other. And so with the biopsychosocial model, we try to explain to every patient that it's neither one or the other, that we're a mixture. We're all a mixture of our biological being, our psychological being, and our social being. And that we try to understand any problem, any symptom, and any disorder with that in mind. So integration of the biopsychosocial model is essential, and it's something that when you come to our center, one way or the other, whether you see the psychiatrist or you see the psychologist, that will be clearly expressed to each patient so that they understand that it's not one or the other, and that their treatment will follow along in that fashion.
Well, Dr. Rosen, would another way of describing this be that this is like a holistic approach where you're looking at the whole person, not just what there might be happening in the brain or might be happening in the family?
Absolutely. You can't separate one from the other. One influences the other just about every second of the day. Whether it's anxiety or stress or mood, they're all related to each other.
One of the reasons that both of us, by experience, decided that the best approach was to integrate our education and our experiences in helping individuals is that the traditional approach, which is in the next slide entitled antiquated approach, really goes back many, many decades and has not changed a whole lot. And that is psychological, psychotherapeutic services would be provided by a master's level or a doctoral level clinician. And the psychiatrist, sometimes nurse practitioner, with or without physician supervision, would provide medication management. And these two would be geographically separated, which can work okay, but the problem is with inadequate communication, never the twain shall meet, so to speak.
If I can interrupt just for a moment, during my own recovery, I had a therapist, I had a psychiatrist, and I don't think they ever even talked to each other. So I was trying to figure out how this is all going to work together.
Well, that's unfortunately rather typical. And adding to that, it was the issue of, well, if you went to a psychiatrist, at least in the last 20, 30 years, most psychiatrists don't practice psychotherapy. So it would either be the psychiatrist would just give you medicine, and that would be that, or if you went to a non-MD, it'd be rare for that person to discuss or recommend any medical evaluation or psychiatric evaluation. So a lot of it was potluck, depending upon whose office you ended up in, as to what your treatment would be.
Yeah.
And what allowed this model to evolve really was in 1992, the two of us joined forces in the same office so that we couldn't help but interact and discuss cases and learn from each other, and it allowed for the development of this integrated model. Not that we invented it, it really has been around for a long time, but unfortunately for a variety of reasons, it never has really coalesced into the kind of model that would function smoothly.
I was always blessed, even before I came to Florida and entered private practice. I worked in my early part of my career, I worked in a day treatment program or for children and adolescents, and it was a team approach. We had a psychiatrist, psychologist, and other disciplines, and there were case conferences, and everybody worked as a team. So I kind of I was lucky enough to never really get caught up in the system of one or the other.
What we also realized early on in working together is that we needed to isolate the critical factors that reflect that biopsychosocial model. More specifically, are the biological factors more critical, or the psychological factors more critical, or the social factors more critical? Because that allows you then to prioritize what we need to pay attention to first in putting together a treatment plan.
And each client or patient is an individual and might need something different.
Exactly.
And so that's how the integrated model got developed. The other advantage of it is most mental health professionals will agree that the career and practice of mental health care is an isolative, lonely existence. Most mental health professionals sit in an office with their client or patient one-to-one without much interaction with their professional peers. The integrated model allows for daily interaction. We're blessed here because of having a total of 10 staff, psychologists, psychiatrists, who interact all the time in the corridor, in the lunchroom, or in discussing cases more formally. So there's ongoing mutual education, case discussion, and most importantly, emotional support. The practice of mental health care can be emotionally draining, and having colleagues around to discuss difficult cases can be very, very helpful.
So that integrated model we're blessed to have in our office. It doesn't exist in many places, but I think more and more we're starting to read about and hear about it. And we'll discuss later what does the patient do who's in an area where there are not necessarily integrated models in one setting. I think there are things that that the patients who are entering into mental health treatment, perhaps for the first time, I think there are things that they can do to sort of create their own integrated model if it doesn't exist.
Could you say a little bit more about that? So I guess I love this idea of, because I'm just thinking how that would have helped me.
Mm-hmm.
So I wasn't trying to have to figure out how does all this work together, or should I be doing more medication? Should I be doing more cognitive behavioral therapy?
Right.
Is it better if I do both? And to be able to be helped in a clinic like yours where that teamwork is starting when I first walk in the door would have been so helpful. So I guess my thought is for our audience is just bear that in mind when you're looking at the options in your area. And if there happens to be a clinic that has more of an integrated model that has the therapists and the psychiatrists in the same setting, or that they're at least communicating well with each other, that is a big plus. But could you say a word about? Yeah, sorry.
No, I'm sorry. I think that's the ideal, is if you can find a setting where it is an integrated approach, where you have the multidisciplinary staff. But on the other hand, if you're in a place where you can't find that, I think one approach for the patient would be, let's say they make an appointment, or they're looking to make an appointment with a psychiatrist if they're thinking, well, maybe my issue is more medical, and they might know, or maybe my issue is I need more talk therapy. Whichever one you go to, or you call even, I think it's worthwhile to ask, well, if you're speaking to the psychiatrist, well, who is the clinician, the psychotherapist or psychologist that you work most closely with?
Ah, that's a great question.
And how often do you work with each other, and how does that work? In other words, press the question, and vice versa. If you're making contact first with a non-MD, then I think it would be important to say, well, who is the psychiatrist that you work with frequently, even if they're not in your office, so that I may want to see you, but I think maybe I'll also want to see that psychologist to get their input as to whether or not therapy would be helpful, and vice versa.
One of the problems that has developed is, especially since much of mental health care is covered by commercial private insurance or Medicare, these models have never really fostered the integrated model. They have their separate provider lists, so there'll be provider lists of master's level clinicians, PhD level clinicians, and psychiatrists, but we need to find a way, as we think about the future of healthcare in general, of fostering this integrated model so that there's a ability financially through insurance companies to help fund the communication more directly between the doctoral level, master's level, and MD level mental health professionals. But that's a long-term goal, and we'll have to see what happens over time.
So if I could just make a brief comment. So what I'm hearing is that for our audience where this does not seem to be available to you either under your plan or in your area, that when you're seeing the psychiatrist, to just ask the question, is there a mental health therapist that you like, that you work with, that you want to connect me with? And then the same thing if you're seeing a therapist or cognitive behavioral therapy, just ask the same question. Is there a psychiatrist that you recommend or that you work closely with? Just so that you can start that conversation and hopefully get more of an integrated approach.
I would even ask it a little different. I would say, not do you have one, but who is the one? We'll make the assumption that you do, because if you don't, that may not be what I want to go forward with. It's just like a patient of mine who needed hip surgery. They did a lot of research to see who's the surgeon in the area who does the most of that particular type.
And you know, one of the areas that's lacking here is we need to help our patients and clients to be much more assertive in asking what's the diagnosis, what's the nature of the problem, and get the mental health professional to define it as well as they can. And then, most importantly, is what's the treatment plan? So if the treatment plan initially is, here's a medication or here's a form of psychotherapy, the next question is, if it's medication recommended, is what is the role of psychotherapy in addition? Because oftentimes people will just accept a prescription or accept a plan of psychotherapy without thinking in terms of, is there more to the picture than we're discussing? And so we need to educate our patients in asking the right questions and being very assertive about what needs to occur.
Good.
So following on that theme, the assessment becomes the real pivotal point of anybody coming into a mental health professional with anxiety or mood concerns, to provide an assessment, to provide as clear as possible understanding of what the nature of the problem is. And it's tremendously helpful to have this conjoint approach, that is, having a psychologist and a psychiatrist together, because it allows us to add the pieces of the puzzle. How much of it is biological, how much of it is psychological, a combination of both. Plus we bring to the individual combined expertise over many years. It's also important to agree that nothing is written in stone, that compared to other areas of healthcare and medicine, for example, if you're diagnosed with high blood pressure, that's pretty black and white and objective, can be measured with a blood pressure machine. But how do you measure depression? How do you measure anxiety? And how much could anxiety complaints represent a depression? And how much could depressive complaints, represent anxiety? And we've all seen, Dr. Rosen and I have had mutual patients, clients who initially we thought had a primary anxiety disorder, and then it began to become apparent that this was really a mood disorder with significant anxiety components.
And when you say mood disorder, you're talking mostly about, for our audience, depression?
For depression, certainly, or even individuals who, have had moods that have fluctuated between highs and lows, which would be a topic for another discussion. But, being able to have that dialogue is really what is the most important component. And certainly identifying whether or not there are more important psychological factors in the form of maladaptive personality traits as we experience the patient together over time. Because, in the beginning, the anxiety or the depression symptoms may seem paramount, but then over time experiencing the treatment between the psychiatrist and psychologist, begin to realize that this individual has psychological issues that are getting in the way of addressing the anxiety or the depressive component.
Yeah, I think it's always more helpful if you can have two looks at the same situation, but it also, if those two looks have a different orientation or understanding, one being more obviously biological, the other one being more psychological, then there is an interface and then an interaction between the two. And I just think you get better results, and the patient generally feels better understood and more actually comforted by the therapy process.
And the clearer the idea of what my main challenge is, whether it's an anxiety disorder or a mood disorder, probably the better I'm going to do, because then I'm going to get better help.
Right. Well, I've seen it in psychiatry where individuals come in complaining of what appears to be a depression, and they go on an antidepressant and they're not getting better. What I've seen happen is another antidepressant is added, and if that doesn't work, another one is added, rather than going back into the huddle and reevaluating the nature of the problem, and are we correct in assuming it's a depression? And that's where, getting input from a multidisciplinary team can be extraordinarily helpful to be able to say, gee, maybe we're going up the wrong limb of the tree in providing a treatment plan.
And wouldn't it be great if the psychologist and the psychiatrist were communicating well together? It could be very helpful.
Well, it's easy to do in our setting, but it's much more difficult to do when you're in separate settings. And then, but I think it's doable if a psychiatrist and a psychologist, who may not be in the same office, but they have an ongoing clinical relationship when they see patients. The typical model, though, has been, one is on one side of town, so to speak, and the other's and they never, as you said before, never speak to each other.
And unfortunately, historically, there have been turf battles where, either psychologists will say, I refer this person to a psychiatrist for medication, and the psychiatrist took over the case, or vice versa. And that can be a major obstacle, and you have to get rid of the turf battles to be able to provide adequate care.
Right.
Good.
So let me go on to the next slide. Okay.
So let's shift to anxiety disorders. Getting into that biopsychosocial model, specifically looking at the biological aspects of it, finding out if there's a genetic predisposition or other family members suffering from the anxiety disorder. So it's looking like it was built in from birth on. The question then is, if the genes are there, but if life goes along relatively okay, the genes may not express themselves as intensely as if their life was not okay and they were exposed to lots of stress and family dysfunction. The other important question is related to whether or not this is a trauma-based or stress-induced disorder. Is there substance abuse complicating the presentation? All too often I see individuals who have been diagnosed with a mood or anxiety disorder based upon alterations in how their brain was working during their years of substance abuse. All bets are off when you try to evaluate somebody's mental state under the influences of drugs of abuse. You really have to see how they are doing a month or two after the brain has been cleared out from the effect of the drugs. And so once we begin to get a better understanding of the nature of the anxiety disorder, then Dr. Rosen and myself will evaluate, is there a role for medication? Is there a role for psychotherapy? All too often, as a psychiatrist, I tell this to my patients, I end up shooting myself in the foot when I'll say, this is an anxiety disorder that can be treated most effectively by cognitive behavioral therapy, and if we use medication, it really would be just either as a rescue agent for panic attacks initially or to improve sleep, but the gold standard of care is going to be cognitive behavioral therapy. But at times there will be signs of depression. Dr. Rosen will come to me with a mutual patient and say, there's more depression present at this point, and we're making some progress in treating the anxiety, but the depression is becoming enduring and needs to be addressed, and at that point, stepping in with an antidepressant may be indicated.
I really love the interplay that I'm hearing and the holistic approach where you're giving an illustration of how a good psychiatrist is going to acknowledge the value of cognitive behavioral therapy, and on the other hand, a good psychotherapist is going to acknowledge the value of good medications.
Well, for instance, if I see a patient who, just has come into me to start, and that patient either has chronicity, they've been suffering for many, many years, and there's a family history, and or the severity of their symptoms is just so bad at the time that they're in such pain that the therapy is going to really have a very difficult time getting started, and it's really also, you have a patient who's suffering so much, they're not sleeping, they're not eating. How could you possibly go ahead and start therapy with somebody who's suffering so much? So, we both weigh these issues when we see a patient, and then we act accordingly. We'll speak to each other, and we then decide if both methods should be utilized, and we'll discuss this with the patient and offer them a rationale for it. And almost always, the patient feels very comforted by that.
Wonderful.
I've over the years, because of the number of years I've been doing what I've been doing, I see a number of individuals who have failed traditional treatment, for example, for anxiety disorder, panic attacks. And I'm just amazed at how many of these individuals have not been told that they need cognitive behavioral therapy. Unfortunately, many areas of this country do not have mental health professionals who are trained in cognitive behavioral therapy to be able to provide it. But in areas where there are a number of individuals who can provide it, it's not thought of. The medication often is the primary route, and that's a mistake in my opinion. Oftentimes, however, we're finding that the most effective approach is a combination of cognitive behavioral therapy with judicious use of medication.
Yeah, wonderful.
If we move on to mood disorders now, again, coming up with a clear-cut diagnosis is critical. I will often share a case with Dr. Rosen or the other psychologists in the group of individuals I've seen where they've had a long history of lack of response to antidepressants for depression, and it's apparent to me that we're missing something, and that's where we'll either recommend psychological testing or further assessment to try to figure out if there are more psychological factors that are interfering with the progress in the individual, and those psychological factors need to be addressed. We need it with depressive disorders to differentiate between persistent depression, which is a complicated area in my opinion because it's not clear how much of that's biological versus how much of that's acquired because of dysfunctional life experiences, from depressions that are episodic and cyclic. Generally speaking, my impression has been that cyclic depressive disorders have more of a biological component, but then at the same time, helping an individual learn how to maneuver in life and deal with stress can tremendously help dealing with the biology of episodic depression. Stress control, sleep control, etc. becomes very important.
Well, that's the other piece of it, is that if you have a mood disorder, whether it be a long-term one or a cyclical one, what comes with that is that a person learns certain behavioral ways of dealing with that disorder and certain coping styles, coping mechanisms, some of which are maladaptive, or many of them are maladaptive. So the assumption, if you just go with the medication approach, will be that once the medication is effective, that somehow these maladaptive patterns will just break away and fall away, and all of a sudden you'll have this person who has great coping mechanisms and different and healthy ones. But what we know is that these old patterns have to be unlearned and new ones put in their place. So again, that's where the cognitive behavior therapy comes in, and other forms of therapy to help a person realize that the coping mechanisms that they were using, that they tried to use, were not working, and we need to replace them. And it wasn't their fault that they were using these mechanisms, but that's all they knew how to do.
So even in a case where, say if I have a serious depression issue and I have a good medication that's helping me with it, it still could be really vital for me to have some good cognitive behavioral therapy to learn some different ways of responding to my stresses and challenges.
Right.
It's really fascinating. If you look at the literature, both psychiatric and psychological literature, for years there have been articles on the role of cognitive therapy in treating major depressive disorder. Major depressive disorder is viewed in the DSM-5 and all the other DSMs as the type of severe depressive disorder that often requires antidepressants. But think for a second of one of the core components of severe depression: lots of self-negative thinking, lots of low self-esteem, lots of confidence, lots of social avoidance. Cognitive therapy is tremendously helpful for that. And so it just makes lots of sense to add the cognitive component to the pharmacologic component, because you get a better outcome.
What I often say to patients is that the medication can sort of serve as a way of breaking up and loosening some of the cement and allow you to get fluid enough and malleable enough to begin to find new ways of doing their lives. And,
I like that.
And then they see it as not only is the medication going to help my symptoms, but it's actually going to make it easier for me to change.
Good.
You know, just this morning, I got a phone call from somebody that I know socially, and he said, you know, there's somebody who works in my office whose wife is very depressed. Is it okay if he calls you to see what services our office can provide? And I spoke with the man, and he said, well, his wife's been very depressed. She gave birth 9 months ago, and for the last 7 months, perhaps, she's been extremely depressed. So my first response is, well, I need to get you in to see our psychiatrist so that we can evaluate the postpartum depression and see if she is appropriate for medication, because she does sound rather severely depressed. But from that, I'm sure that some type of psychotherapy will be involved to help that person deal with whatever psychological aspects of this postpartum depression have evolved, including, you know, shame and negative self-esteem and questions about who they are and what kind of a mother they might be, and all the things that we know occur with postpartum. So again, how can we just give a pill?
Good.
Which brings us back to this whole team approach. I mean, the kind of case that Dr. Rosen just discussed, you know, he'll catch me in the morning in the corridor and say, you know, I got a call from such and such about such and such, and then does it make sense? Do you think they should see you? And I'll see the individual, for example, to assess that aspect of it, and then touch base again with Dr. Rosen to talk about the rest of the treatment plan so that we can coordinate it. And that's really what the integrated approach is all about, which then allows for, you know, the team to continue to communicate as progress or lack of progress is made. You know, there are a whole bunch of cases that the two of us have been involved with together who have had lots of ups and downs and have not made the kind of progress we had hoped, but it requires that each step of the way that we try to troubleshoot and brainstorm as to why they're not making progress, so that eventually we can get to a point where enough progress is made so that the original problem has begun to abate. And this kind of this concept of real-time office discussions is absolutely critical. For areas where you're not in the same office, you know, phone calls and now emails make it much easier. I know I benefit tremendously from the non-MD mental health professionals in the community who keep me up to date by emails and allows me to do the same after seeing somebody in my office to communicate back to them. It allows for checks and balances, because there have been times when, you know, Dr. Rosen will say to me, you know, I don't really think we're going in the right direction with this medicine, or my patient's telling me that they're worse, because it's a reality that the psychiatrist who provides medication will only see the individual on some kind of schedule, but it's much less frequent than the psychotherapy being provided by the therapist. And so the clinical picture that the therapist is able to obtain has much more information than the snapshot that I may get in an office visit once a month.
So we can only say great things about the team approach, and hope that the fragmented approach becomes a dinosaur really quickly.
Yeah, me too.
So with some medication issues, I'll let Dr. Gross talk a little bit more about that.
Well, you know, the hard science comment is really taken quite seriously. It isn't a hard science. If you look at the data that's always changing in medicine in general, you know, there was a time when a woman around menopause who had first complaints of depression would be referred to their gynecologist for hormone replacement therapy as the first-line treatment for depression. And then more data came along about the potential risks of cancer or heart disease in women, and that changed. Same thing is true in psychiatry and medication as well. So I think it's important to help our patients understand that we think that this is a medicine that can help, but we need to evaluate it over time. How long one should take medications is always the toughest question. Clearly, if somebody has had a chronic disorder or a episodic disorder, one of the goals after the initial treatment of the acute problem is prevention. And there are medicines that we can use to prevent that, but there isn't a hard science out there as to how long somebody should be on an antidepressant if they've had a single episode of depression. Current recommendations are 6 to 12 months after feeling better, but that's basically been a consensus. There's not been a whole lot of strong research in that area. There needs to be. One of the advantages of the team approach and the integrated model is that if we take panic disorder, for example, I will tell the folks that I see that because of the tremendous benefits of cognitive behavioral therapy and the fact that you will take ownership for the skill sets that you learn to control the panic anxiety, there won't be a need to be on medication indefinitely, because this will become built into how your brain functions and how you function psychologically in the world.
So the answer to this question is going to be very individual, and it also might relate to what is my main issue. So if it's panic disorder, then, well, a lot of people where that's the main issue could have a plan of weaning off medication if they want. On the other hand, if it's a different issue, say I have a persistent depression and I've gotten a lot of help from a particular medication, then there might be a different answer to this question.
Now, I see many individuals who have been placed on medication years ago and have just stayed on the same medication. I see this more oftentimes when non-psychiatrists provide the prescribing, like the family doctor. It's almost as if it becomes built in, but I think it needs to be reevaluated. I will, see individuals who've been on medication and stable for a year and say, there's nothing to indicate that you need to stay on it because your depression appeared in the face of lots of life stress, and your life situation now is much improved. The issues that were causing you distress a year ago or 2 years ago have vanished, thankfully. You're coping much better, and the life situation's much better. So where is it written that you need to stay on the medication? So at that point, make the decision to very carefully decrease the medication as a test each step of the way, and if they do okay with each reduction, you can then say at some point you don't need the medication anymore.
Now I have a question. Actually, a couple people sent in the same question. So someone who is being treated for anxiety disorder, and the question is, why am I getting a medication that's called an antidepressant because I don't have depression?
It really gets back to the whole concept of language and what the word anxiety means. When you ask, in my experience, when you ask most people what they mean by anxiety, they will tell you they're talking about overthinking, worry, rumination, apprehension, fear, catastrophic thinking. There are really two big components to anxiety. One component is psychic, which is the latter, the overthinking, the obsessing, the ruminating, the catastrophizing, the what if this, the what if that. The other component is somatic or physical, rapid heartbeat, shortness of breath, gurgling stomach. But my experience is that most anxiety complaints are psychic. And the antidepressants, the serotonin antidepressants especially, have anti-obsessive action. And that's why they're helpful.
So they're helpful, even though they're called antidepressants, they can be helpful for anxiety.
Yeah, they were developed for depression originally, but when you look at their actions, especially the newer generation of selective serotonin reuptake inhibitors and some of the serotonin norepinephrine reuptake inhibitors, they all have anti-obsessive, anti-worry, anti-ruminative effects.
I see. Okay. So the reason that if I have an anxiety disorder but I don't have depression, it's very possible that the reason the psychiatrist prescribed me a, quote, antidepressant, say something like Paxil or Luvox or Zoloft, an SSRI medication, was because of my anxiety, not because he thought I was also depressed.
That's right. And, you know, if you think about it, the antidepressants go back to the late 50s, early 60s, and nothing has changed in our nomenclature. There's a movement now in psychiatry to try to redefine what words we use to describe psychiatric medications. So there may come a time when medicines like fluoxetine or sertraline, Prozac or Zoloft, for example, will be defined as antidepressant, anti-obsessive, anti-panic agents rather than antidepressants.
More specific.
Yeah, good. There's another question that a couple people sent in, and this is specifically about taking an SSRI medication like Paxil or Zoloft or Prozac or Luvox. And the question is, you know, I did really well with it. This is both of the questions were they had an anxiety disorder. And the question is, I did really well with this medication for quite a few years, and then unexpectedly, and I can't figure out why, it really seemed to just stop working. I can't figure it out. Is it what? Any thoughts on that kind of experience?
Oh, that's the poop out syndrome. The technical term is tachyphylaxis. We don't really understand why people will no longer have a response. My suspicion is it has to do with some kind of change in brain chemistry and the influence of these medicines. But you know, it gets to the integrated model again, which is how many of these individuals had the advantage of doing the cognitive behavioral therapy to deal with their anxiety disorder, or pursue mindfulness training, meditation training, etc. But it is a problem that we see, and this day and age, with the number of generic manufacturers, believe it or not, the first question I'll ask a patient when they come in and they describe poop out is whether or not the generic manufacturer for their Prozac has changed. Because even though there's supposed to be a very significant similarity between the actions of the different generic manufacturers of the same medication, my experience has been there is a rather large differential. And time again, when I put somebody back on the original generic that worked, they get back the response.
Oh, very good point. I hadn't thought of that. So take a look.
It's come up a number of times in my work with patients, and that's one of the things that I've also learned that we have to ask the question, and I typically do now, is I don't assume anything. I'll even ask that question, by the way. And then the other piece of that is, you know, as Dr. Gross was saying, there's that poop out syndrome, but a lot of times patients who are on medicines that have been working well, they have this sort of not necessarily a conscious understanding that they think that medication should really insulate them from all of the life situations and stressors and traumas and speed bumps that occur in their lives, and so very often they don't necessarily have an awareness that maybe something happened that impacted on their mood. It wasn't just the medicine that pooped out. Now, more often it's I think the medicine pooping out, but still we have to, the teamwork approach looks at that, you know, and asks, well, has anything happened in the last 6 months that maybe you thought didn't make much of a dent, but let's take a look at it again.
So we got a couple of, sorry, go ahead.
And I'd like to raise a bit of a controversial issue around poop out, and that is therapist poop out. It's a real phenomenon. Individuals will say, you know, I'm not getting out of my therapy what I used to. You know, that we started doing lots of good work, and now suddenly it's like we're just having a friendly chat. And that does happen, you know, and it's not to blame anybody, but it can happen sometimes with long-term therapy. And that's why I think with having colleagues around in a team approach, it gives you the opportunity to reassess where you're going, where you've been, and how the treatment plan may need to change if ongoing care is necessary.
Another couple of really good questions about medication came in. So here's one woman who is thinking about, she has had one of the SSRI medications and CBT, and is thinking that she would like to go off the SSRI medication. In this case, it's Paxil. And the question is it okay just to stop taking it, or is it, how important is it to do a gradual tapering off of a medication like that?
the basic rule of thumb is any serotonin agent that has a short duration of action, of which most of them are short duration agents, if you stop it too quickly, there's what's called a discontinuation syndrome, which is like a withdrawal, probably representing a rebound of serotonin effects. And it can be very uncomfortable, not dangerous, but uncomfortable. The person can have...
But you're not advising that I go cold turkey off of that kind of medication?
No, that's the mistake, especially Paxil. That agent is known to have significant withdrawal discontinuation symptoms, and so it needs to be decreased rather gradually over time.
Okay. Another question is, are there some medications that can be addictive that I should be cautious about?
For anxiety disorders,
yeah,
especially
for anxiety, yeah.
The medicines that are tranquilizers, especially the minor tranquilizers in the benzodiazepine family, which are Xanax and Valium and Ativan, Klonopin, Cirox. The word addiction is a bad word because when used in the right framework, it really refers to abuse of a medicine. But the question is, will these medicines lead to dependence so that I cannot just stop it abruptly, because if I do, I'll have withdrawal, and tolerance, meaning will I no longer have the same kind of response that I did in the beginning. And
so I might have to end up taking a lot more of it to get the same...
Exactly. You have to keep it no different than, the alcoholic who found that they get tipsy after two drinks, and now they have to have 3 or 4. So, you have to be very careful about the use of these agents, and it certainly cannot be stopped abruptly. There are other anti-anxiety agents that don't have the same kind of effect, but they're generally tranquilizers that belong in the major tranquilizer group that are best described as antipsychotics, and they're really used off-label for severe anxiety and agitation. They don't have the kind of withdrawal that the benzodiazepines do.
Is there a preference in general for anxiety between the SSRI category and the benzodiazepines, that the ones you're talking about now?
It's a good question. I mean, that's something that Dr. Rosen and I discuss on a regular basis, because what we'll often talk about is there a need for an SSRI in this person who has a panic disorder? And much of the time, the pharmacologic plan will be to use a short-acting benzodiazepine as a rescue agent for the panic attacks to allow for the beginning of cognitive behavioral therapy, with the notion that if cognitive behavioral therapy progresses, there may not be any need for an SSRI. The only thing that I ask the individuals that I work with is that if you and your psychologist doing cognitive behavioral therapy feel like treatment has stalled or reached a plateau, then you may want to step in with an SSRI and improve the treatment. But I also tell people that, especially if there's lots of overthinking and worrying and anticipatory anxiety and a pre-morbid or pre-existent tendency to worry, sometimes adding on an SSRI at the same time that cognitive behavioral therapy starts can often speed the progress.
Very often you can just tell whether the amount of overthinking and worrying and obsessing that this person does is just so global and so entrenched that you know they'll need that. But most of them don't.
Now, if I'm just taking Xanax or Ativan or Klonopin for my, say, panic disorder as I'm starting to do my cognitive behavioral therapy, would a good plan in general be that I want to just be taking that medication for a short period of time as opposed to like an ongoing long-term plan?
Yes, because the reality is most of the benzodiazepines, Klonopin, Xanax, Valium, Ativan, etc., begin to lose their effectiveness after a short period of time. And so, when they're used regularly, once or twice or 3 times a day, 2 to 4 weeks later, the anti-anxiety benefits have reduced significantly. and you don't want to have to increase the dose. But this gets back again to the integrated model and the critical importance of communication between, you know, the psychiatrist and the non-MD mental health professional to talk about progress, to talk about, are we at a point now we can begin to decrease the anti-anxiety agent. One of the things that happens is people who have panic attacks, as you know, a panic attack is god awful, and it's like the person's going to die, the world is ending, etc. So the psychological value of having a Xanax to take can be tremendous. So it almost becomes like a rabbit's foot. People are frightened about getting rid of the minor tranquilizer or the Xanax, for example, because they fear that they'll have a total return of their panic anxiety, and it requires a lot of reassurance and cognitive work to help them recognize that yes, they're able to move forward and safely stop the medication.
There's another phenomenon that occurs as well with the benzodiazepines. If we start out with treatment, obviously the patients quickly responded and they're feeling much better. But in order to go through cognitive behavior therapy successfully, you do need to feel some degree of symptomatology. If you feel great, if you're not feeling any symptoms, you lose your motivation rather quickly to do the hard work that's involved in the cognitive therapy. So I explain to my patients that it's not a good idea if they feel great. I just want them to feel reasonably well, but symptoms we need as grist for the mill to help them learn the tools to overcome those symptoms.
So what I'm hearing is that maybe a role of benzodiazepines for a lot of people could be just to help me get started, to be in not such overwhelming distress that I can't even, you know, do any homework at all, but I can get started with the cognitive behavioral skills that I want to be learning.
Right.
You know, we left out one of the critical aspects of integrated model in that much of the psychiatric medication prescribing is done by primary care providers or the family doctor, not by psychiatrists, because there aren't enough psychiatrists to go around, etc. The integrated model is possible there, but it requires even more communication. You know, the family physician is not going to be as sophisticated in the use of these medications, and it's terribly important for the mental health professional to provide regular communication with the family doctor so that, for example, if Xanax is being prescribed for panic attacks, that 6 months later you don't find out the individual is still taking Xanax regularly when it wasn't necessary.
Yeah, good. I think we have time for maybe a couple more questions. So here's another really good question that came in. For my anxiety disorder, if I take one of the medications that is recommended, I think she's talking about one of the SSRIs. How long should it take to start to see some improvement in my symptoms?
The SSRIs require lots of patience, and that is for two reasons. One is that if you take a person with significant anxiety, panic, obsessing, worry, and start them too quickly on an SSRI, it can intensify the anxiety.
So you have to be patient when you're introducing that.
You have to start at a low dose, which means it delays the ability to respond. You know, there are three major factors here with medicines like this. One is it the right fit? Is it the choice of the right SSRI for that individual? Second factor is, have you built up to an effective dosage? And third, and most important, have you been on it long enough for it to be able to be effective? And that's, so lots of patients require, that's where it's so helpful to have the integrated model, because as the individual is waiting for the medication to help, you know, they're also working with the non-MD mental health professional, and in the beginning, if they're not in an emotional state to be able to tolerate cognitive behavioral therapy, they certainly can receive supportive psychotherapy to help them move in the direction of then being able to use the cognitive behavioral therapy.
Similar question. So let me ask the same question. Say someone has an anxiety disorder and they're not taking medication, and they're starting cognitive behavioral therapy. Same question. Maybe Dr. Rosen, you could address this one. I'm starting CBT for my anxiety disorder, how long should it take before I start to see some improvement?
Well, I just got that question asked from a young man yesterday. He was at about 5 weeks into his treatment, and we did start him with some rescue Xanax. He had panic disorder and a lot of avoidant behavior. And he asked me yesterday, like, you know, how long is this going to take? Because I don't feel great. I feel better, a lot better than I did when I came in, when I wasn't sleeping and I wasn't eating and I just couldn't even get out of the house. Doing much better now, but how long will it take for me to really get better? And so my rule of thumb is, and it's been this way for quite some time, is that by about the 8th week, I should start to see some really significant improvement in the overall status of the person, both in their symptoms, their degree of relief and hope that they're going to get better, and that they've kind of bought into the process, that they're in the right place and that they're starting to feel better. But I usually, depending upon the type of anxiety disorder and the chronicity of it, whether it's been more recent or not, I usually tell them it's going to be at least a 15 to 20 week process of regular treatment, ongoing regular treatment, and then at around 20 weeks we can start to figure, in many cases we can start to taper down in terms of frequency of sessions. So that's a very big ballpark, but somewhere in that range for the cognitive therapy process to take over, and for some of the behavioral changes to occur, and also for what I kind of call the muscle memory to take over, where some of the changes that have occurred aren't taking so much hard work on the part of the patient, that some of the changes in the way they think or process situations starts to become a little bit more reactive and quick, rather than a lot of clinical work to do it.
I think we have time for one.
There's a piece of that I see from my perspective that's real critical, and that is that the cognitive behavioral therapy can be very, very helpful and critical, but there has to be an initial therapeutic alliance, and that can take a few sessions to develop, and that's a very important aspect of it.
Yeah, good. I think we have time for one more question. So this is a question from a woman who was taking, I guess she was taking Zoloft for her anxiety disorder, and said that after taking it for a few months' time, she found herself having difficulty feeling emotions in a normal way, that there was a kind of a numbing of her emotions. Is that something that many people experience, or would there be some other issue that might be going on with her?
No, that's a very good point to raise. I remember in the beginning we talked about the concept of anxiety being divided into two areas, somatic and psychic, with lots of obsessing, ruminating, and that the SSRIs are anti-anxiety because they're anti-obsessive. If you go to an extreme of anti-obsessive effects of the SSRIs, it can make somebody feel too mellow and not experience the level of emotionality they would like to. And I view that as a side effect. Oftentimes it's best addressed by decreasing the dosage. Sometimes it requires stopping that particular medication because it may be that particular SSRI was too potent for them in that respect. I had a young lady tell me that she knew that the medicine was making her too emotionless or mellow because she was at her favorite aunt's funeral and she didn't cry. And so it is a real issue. It needs to be addressed. Fortunately, it's not common, but it can't be ignored.
Yeah, wonderful. Well, thank you so much for your presentation, and thank you everybody for participating. Both of our presenters, yeah, thank you. And both of our presenters have very graciously agreed that they'd be happy to respond, schedule permitting, to questions that you have on this topic. So if you'd like to ask a question, you can send an email to webinars@adaa.org, and you could, in your subject line, maybe put Dr. Rosen, or Dr. Gross. So thank you so much for participating, and we'll see you next time.
Thank you.
Thank you.